Well, good morning, everybody. This is Jeff Davis with OPRA. I'm here with Anita and Christine, and of course, the great Scott Phillips with DODD. We are so pleased that you've joined us for this webinar. We talked this morning about the proposed MUI rule changes. Scott's going to cover these in some detail. We're going to back that up in September with our Back to Basics training. We're covering the MUI rule and the entire MUI process in September, along with behavior supports and restrictive measures. So we hope you'll join us and register for that. I'm not going to waste much more of your time. I think we'll just turn it right over to Scott and we'll go through the changes. What we're going to do here too is record this. So we will put this up, on our website, as shortly after this webinar as we possibly can. So you'll have it as a resource, and we'll come back and do this more and more. And I think Scott will chat a little bit about, where we are in the process with the review changes, and then he'll go over some of the changes in detail. So again, we are so very grateful you've joined us. You have a process, I think, for typing in questions or comments, right?
Yes.
To do that?
Yes, please type your any questions you may have in the chat box, and we'll read them out loud. Before we get started, though, just to make sure everybody can hear us, can someone please type in that you can hear us? Yes, okay. Thank you, Laura.
That covers it so you don't have to hear me again. Okay, Scott, it is all yours. We are appreciative that you're here as well.
Awesome. Well, thank you, Jeff, and thank you, everybody. I know how busy everyone is, so thanks for taking a piece of your day out to talk with us. I just will tell you this, I've been a part of several rule reviews in my career, and this is one of the best that I've ever been a part of. We were lucky to have some tremendous stakeholders, and I think just to start off, I wanted to tell you a little bit about kind of what we do in terms of preparation for the rule reviews. We think about what we've got in place, how can we make it better, who do we have to have in the room to do it, and I think we did a really nice job this year of making that happen. Some of the things that we were thinking about in advance, and for those of you that don't know, this is the third time around that the MUI rule has been discussed since it's been created, so we're refining, we're not rebuilding. We're refining what we've got, and in order to do that and to do it well, we thought ahead of time before we brought in the stakeholder group about what we wanted to do. And several things we wanted to do is we wanted to have a renewed focus on prevention and quality improvement and partnerships. MUIs over the years have kind of gotten a bad rap, and it's not that they're good things that happen. I get that, but it's a quality improvement process. And we wanted to make sure that folks realize that we're here to focus on prevention, quality improvement, and to try to build some collaborative partnerships while we do it. And we wanted to make sure that this group had that discussion. And I can tell you from many of the discussions we had there that I felt like that happened. We also wanted to think about the shift that we've had from to the community and person-centered plans. I mean, you got to be able to balance risk with quality of life. And really, if you think about it, our health and welfare system, that's what we should be doing, is balancing risk and improving quality of life. So we want to talk to that group about how we do that. And I think you're going to see some information we discuss on how we talked about that. We also want to talk about opportunities to increase communication. We've got a really good system, a robust system, but sometimes we leave people without the information they need during the process. And how can we improve communication and do a better job of that? So you're going to see some areas where we've tried to address that. We also like to minimize the administrative burden. We don't want to make it any harder than it needs to be. We want to have a good system in place. We want to have it well documented, but we don't want it to be overly burdensome for providers or boards or the department. So we want to try to take a look at that and how we could maybe reduce some of those administrative burdens. And then finally, I think it's important for you guys to know, and we had a lot of discussion in the committee about spotlighting some of the positives. A lot of times when we're looking at MUIs and we talk about what happens, sometimes it's not the best information to share. But when you're digging down and you're drilling down into some of these cases, you find some amazing work that's done by direct support professionals in the field. It's amazing work. And I'm going to talk to you at the end of the day about, or at the end of the presentation rather, on some of the stuff that we talked about there. But really, just wanted to reinforce for everybody how important the MUI process is, how important protecting the health and welfare of folks is, and how we need to think about the whole system and how we do it well to protect the system as well. To just give you some information on how the actual process went.
Oh, sorry, someone had an issue with their.
Oh, okay. No worries. So to talk to you a little bit about how the process went, we started back in May of last year because we knew this was going to take some time, and we wanted to devote the time that we needed to talk about this and get our work group together. So between May and February, we met 7 different times, and we always had good suggestions. We would take away information, build the review, the draft rule review, bring it back, hit it again, and try to refine it. We did that multiple times, and we had some terrific representatives, individuals and families. OPRA was there, OACB was there, the ARC, Ohio Waiver Network, Ohio Healthcare Association. I mean, we had the right people in the room to have all the discussions that we needed to have surrounding this rule, and got some really, really good feedback throughout that process. We also, during the time we were having the rule stakeholder meeting, had some involvement with other members. We went to the OPRA conference a couple times, Project STIR, talked at the PAR conference and at OACB to try to get more feedback, even outside what we had in the stakeholder committee, which I thought was really good. We added that information into the draft and then ended up landing in a place where everybody felt pretty good about the outcome of that draft. The draft then went to the rule review clearance, and all of you hopefully got to see it there. We got some good feedback through the clearance process. We've responded to that feedback, and now the rule actually has been forwarded to the governor's office for the Common Sense Initiative review. Once that's completed, then we're going to have some follow-up. There'll be a public hearing, and we'll set an implementation date. And right now, if all goes well, and we don't expect that it won't, we're looking probably at a likely start of beginning of the calendar year, so probably January of 19, if everything falls into place. Obviously, that's still subject to some change, but we feel like that's probably going to happen and make some sense. And then moving forward, once we get a start date, you know, we want to make sure that we do a good job of sharing information, providing education. We've asked the stakeholder group to be a part of some of that, to help us with some of the training and to kind of go out and do some regional trainings. So we also want to think about different communication strategies we can use for training. And as you guys know, the social media is amazing. You know, we can do webinars, we can do Facebook Lives, we can do taped PowerPoint presentations, we can do face-to-face, and we plan on doing all of that to make sure that we get the information out as quickly and as thoroughly as we can. Because obviously it's going to require some policy and procedure revisions. And the other thing we want to make sure we do before we close out the training session is to figure out a way to evaluate the impact of the changes. Every time we do a 5-year review, it impacts our data. So we've got to make sure that we make the notes and that we take a look at how the changes are impacting the data so that we can do some more analytics and drill down further into the data with outcomes. So that's where we're planning on going. I think that's given you just a little background on where we started, how we kind of completed, and kind of where we're at today. And then I, again, appreciate Jeff having me out to kind of just give you an update on some of the draft changes. We'll get into those now. The new number, those of you that are numbers people, 5123 used to be 21702, and that 2's been removed. I guess there's a different way of numbering the rules now, so 5123 1702 will be the new number. The actual MUI definition really didn't change dramatically. We took a little bit of the language out, and the reason we did it is every single MUI, all 19, have their own definition. So really what we said MUIs are is MUIs are these incidents, C16A, B, and C of the rule when we have reason to believe that the incident occurred. And then the incidents speak for themselves. The definitions of the incidents speak for themselves. So there really wasn't much change there. There was a lot of discussion about peer-to-peer acts and those investigations. And the committee's recommendation was to move those from a category A to a category B. And all of you know that MUI investigations are done in category A, B, or C. All 19 are defined, and really that's a way to triage the type of investigation that you do. So we're still going to get good, thorough peer-to-peer investigations, but the committee felt like it was more important, and they fell more in line with the category B outcomes, which did make some sense. So that was moved to category B. In addition, we also defined DD employee differently, and we defined DD employee to be that way it's defined in all rules through the department, and that was to add board member. You can see here we added board member to the definition of the DD employee. So we're talking about any employee, superintendent, board member, or employee of a county board, an administrator, board member or employee of a residential facility, board member or employee of any other public or private provider, and then an independent provider. That pretty much captures all the DD employees within the state of Ohio. So that's really the only change to the definition of DD employee.
Okay, Hans. So we've had a couple people ask if we can get a copy of the PowerPoint. The PowerPoint we sent it out through the listserv this morning. So if you didn't get it or you're not on the listserv, if you send me a private message, so send Anita Allen, the presenter or the organizer, a private message with your email, I'll make sure that you get a copy.
Okay, so let's move to the neglect definition. And the committee took a lot of time to discuss the neglect definition and how we look at neglect here in Ohio, and I think it was very well justified. I mean, for those of you that know the specific definition in detail now, you know that it's a very broad definition. And it was done purposely so that we captured all those kind of things where there was potential risk and put a prevention plan in place to help. So, you know, when it was created 5 years ago and we had that definition, this definition made a lot of sense. What the committee talked about and what I've seen personally through review of cases at the department is it's gotten so broad that sometimes cases that truly aren't neglect get lumped into the current neglect definition, and that's not what we wanted. We had a lot of discussion about how investigating MUIs impacts providers, families, the workforce, and we don't want to do that kind of investigation unless it's truly warranted. So what a lot of the committee discussed in this go-round was how could we maybe narrow the focus of the neglect definition to make sure that we're getting the neglect MUIs that we really want to be investigated by investigative agents out there through the boards. And so you can see here the existing language. When there's a duty failing to provide an individual with treatment, care, goods, supervision, or services necessary to maintain the health or safety of the individual. Again, that's very broad. You take a look at the proposed language, and you can see that we've narrowed the focus to still the duty, but when it's you're providing medical care, personal care, or support that results in serious injury or places an individual or another, that's okay, at risk of serious injury. And then we've defined serious injury as an injury that results in treatment by a physician, physician assistant, or nurse practitioner. So there's going to be a lot of training that goes along with this particular definition change because I don't want people to think that we're really relaxing the definition of neglect. We're not. And you're going to hear in a few minutes that we're going to capture everything that we still report in neglect as neglect now to be investigated. It's just going to be a little bit different. So that the neglect MUI that's going to be investigated by an investigative agent through the board will be the proposed language that involves serious injury or a risk of serious injury. And just to give you an example of a couple of these, you know, currently, you know, if somebody is not supervised for a short period of time and they have required supervision levels, there's no negative outcome. Many times those are still filed as a neglect allegation. And what our hope is in the future, and we're going to talk about another category that's going to capture some of these, that those particular kinds of cases would not be filed as an MUI for neglect, but will be filed as our program implementation UI, and we're going to talk about that here in a second. So I just wanted to make sure you guys knew that there was a lot of discussion, almost every single meeting of those 7 meetings about the neglect definition, and we worked really hard to try to come up with one that we felt made sense for everybody, for individuals and families, for providers of service, for the board, and for the department. And I think we landed in a place that makes some sense. In addition, when we were talking about neglect, many of you know that you've probably seen the outcome of some neglect investigations in the state where it's identified as a system neglect, and we didn't have that defined in the previous rule. We felt like it really needed to be defined in the current rule. So you'll see system neglect now defined as substantiated MUI attributed to multiple variables. So that's when we don't have one single person that we're saying was neglectful, yet the person was still the subject of a neglect substantiated outcome. Let me just give you an example because I think that's helpful. So we had 3 individuals living in a home. There were 2 employees working there. One of the individuals was a one-to-one. The other one was not. One of the employees has to go use the restroom and says, hey, to the one-on-one staff, hey, can you watch these 2 guys real quick while I go to the restroom? I'll be right back. She says, sure. The minute that person leaves to go to the restroom, one of the individuals goes out the front door. Now this person's assigned a one-to-one that they're with. The other person goes out the front door towards the street. The other person can't be reached. The other staff person can't be reached. So that person has to make a decision. In this case, the person made the decision to go protect the person from going out into the street, brought the person back. In the meanwhile, the person that she was one-to-one for had a pretty significant self-injurious behavior episode, hurt herself pretty badly. Again, we had a situation where a person was neglected. However, that person was in a no-win situation. So that's the kind of investigation that may come back with a determination of a systems neglect. And really, we have to take a look at what happened that allowed that person to be in that position, so that systemically we can fix that and make that better. And I think that there was a lot of good discussion in the committee about system neglect and what that truly meant. The other part of changing the neglect definition was adding a definition to the rule that we never had before, and this is called Program Implementation Unusual Incident. So this is a UI, and this is a UI that involves the failure to carry out the person-centered plan when such failure causes minimal risk or maybe no risk. Examples include, but are not limited to, failing to provide supervision for short periods of time, automobile accidents when there is no harm, and even self-reported incidents. We had some folks that would self-report that they fell asleep during their shift. And if that person was placed at risk, there was concern about that under the current rule. With the new rule, that would probably fall under a program implementation UI. Now, these are going to be investigations that are done by the provider of service, because it's a UI, right? So this is going to be done by the provider. So the only way that this all works well, these system changes work well, is if we really do a good job of still making sure that those investigations happen the way they need to, whether they're done by the IA or whether they're done by the provider investigator assigned. So I hope that makes sense. So in a nutshell, to wrap these two slides up, we're not going to be not reporting anything that we don't report today. It's going to still be reported. The difference within the draft revision is MUIs are going to be more clearly defined and be the higher level cases involving serious risk or serious harm. And the UI issues related to this are going to be program implementation investigated by the provider of service.
We have a question online.
Sure.
Andy asks, how are serious injury and minimal risk defined?
Yeah, and it's going to be, there's almost no way, and we talked about that in the committee numerous times, it's awful hard to define that. So what we plan on doing is, and I hope you've seen these, we've done the, last year when we did the rule, or last time we did the rule, we did the interpretive guidelines, and we're going to try to put information specifics on what we're looking at in terms of serious risk of harm, to try to make sure that's identified. And we actually did define, we tried to define serious risk in the current rule as well. There might be still some changes with that, so I haven't got that here, but we will try to define it. We'll make sure that it gets handled in the training piece as well. It's a good question.
And then we have Beth asked, can you give some more examples of this one? Sounds like it's up for interpretation. I believe she's talking about the program implementation.
Yeah, so the ones I think that are most important that we've seen currently that are, I'm about to break the chair here, that are, that come in currently as MUIs for neglect are really the supervision issues. So somebody's not gotten the supervision they need for a short period of time. Maybe they do have some risks noted in the plan, but it was a very short period of time and there was nothing that occurred. You know, the provider can get right on top of that, can make the adjustments, can do what they need to do. I think that's really what we're talking about. Those are most of the examples as it relates to supervision, primarily. So I hope that helps.
A follow-up to that, if it causes no risk, how can it be unusual?
And it probably wouldn't. So if there was no risk, then, I mean, and providers of service currently, and you guys know this, write up UIs for all kinds of things. We're not saying you couldn't write up a UI for whatever you want, but if there really wasn't any risk, there probably isn't any kind of issue related to that. But most providers do UIs for anything that impacts health and welfare, even when there's not a lot of risk.
Right, difference between no risk and minimal risk.
Exactly.
Beth, did that answer your question? Yeah, all right.
All right, great, thanks, Beth. All right, moving on to the Peer-to-Peer Physical Act. This one took a lot of the committee's discussion time too, and you know, I think it's one of the hardest definitions that we've had over the years to define. And you know, we try to make a delineation between a peer-to-peer act that's MUI worthy and a peer-to-peer act that is UI worthy, and that's a hard sometimes a hard decision to make. So our current existing language, you guys know that we had this in the last time. We put targeting and firmly fixed, and we were getting all kinds of questions because it's really hard to determine whether somebody was firmly fixed. It is hard. And sometimes it's even hard to determine whether it was officially a targeting issue or not. So we decided to remove those words completely, remove targeting and firmly fixed, and focus more on the significance of the injury and the outcome. So you can see the new draft language talks about a physical act, which means an altercation that results in the examination or treatment by a physician, physician assistant, or nurse practitioner, involves choking or a concussion or trauma to the face, or involves a bite that breaks the skin. There were some significant peer-to-peer issues that were bites that broke the skin that were pretty dangerous, or results in the person being arrested, incarcerated, or charged. So try to remove the firmly fixed, remove the targeting, focus on really what was the outcome of the peer-to-peer physical act as it relates to the treatment by a physician, physician assistant, or nurse practitioner, or one of the significant injuries that's listed here. So we're hoping that that's going to be a little more clear. We'll probably still have to do a lot of training and talk about what we're still specifically looking for, but we're hoping that it's going to be a little bit easier for people to determine what's the difference between an MUI peer-to-peer and a UI peer-to-peer. Some other changes with regards to Category B, just to keep you in the mix. So prone restraints, you guys know currently somebody does a prone restraint, it's filed as physical abuse. That was done the last time we did the rule because we felt like this is a banned restraint. People know it. If someone does it, and we know the risks associated with it, we want to investigate it as physical abuse. Many people on the committee felt like, even though that is true, that it's still a restraint that someone's doing. It really should start as an unapproved behavioral support. And then if we see that it was utilized in a way that it shouldn't have been, then we can still raise it up to the level of a physical abuse MUI. And so we decided that made sense. And so it'll be originally filed as a UBS. And then if we get more information, we think it should be elevated to physical abuse, we can do that. You guys know that MUIs can be moved around. I mean, it can be filed as something, and then you find out more detail, and you can move it into some other category. So that's what we made the determination to do for UBSs and for the physical abuse. Medical emergency definition changed. We had several people give us feedback that they were using the defibrillators, the AEDs, and so we added those to the medical emergency definition. So that's clearly a life-saving measure, right? We want to make sure that's included. The other thing we kept having concerns about related to the medical emergency definition was people being confused about when an IV was used that was a medical emergency and when someone just got an IV because everybody gets an IV whenever they go to the doctor or the squad comes out. So we took out the IV for dehydration because it was just too hard to determine when or when not that was a medically emergency medical intervention. So hopefully that'll be helpful because we had a lot of questions about that. But we added the AED and we removed the IV just for basic dehydration.
Scott, can we go? We have a question about the peer-to-peer to take
Sure.
us back. What about above the neck injuries?
I think we tried to capture above the neck with the injuries that we've got here. So, the bloody nose, the concussion, the black eye. So, that does make sense. Basically above the neck injuries is what we're talking about here. And there's still going to be some discussion about whether or not this particular injury is a peer-to-peer MUI. We're again hoping to put into the interpretive guidelines and the frequently asked questions information about what are some examples of what we're looking to make sure is in that category. So I hope that helps.
Wendy, did that answer your question, or do you have follow-up? Yes, okay. And
Great.
then if you go to the next one, we got a couple questions on IVs.
Okay.
So it's still an MUI if an IV is used to administer life-saving medications.
Yeah, so again, this is still, we realize that it's not always easy to identify what the IV was used for. If we know it was for a life-saving intervention, sure, it's fine. If we don't, and you aren't sure, we're not gonna expect that you know that or do that, because IVs just happen, routinely for a lot of different reasons. So if you happen to know, great, and you can file it. If you don't, we're not gonna press it because many times we don't know what the IV was really used for.
Okay, and then if you're diagnosed with dehydration and it's on your hospital discharge, would that be considered a medical emergency?
That's a really good question, and one that probably we can consider on a case-by-case basis. I'll talk to our medical folks to make sure we try to get an example of when we want to make sure that that IV is listed as a medical emergency. That's a really good question.
And then we have one, sorry, take us back
Oh, you're good.
a few more slides.
That's fine.
This one just came in, this one. So in terms of short periods of time and supervision, is that referring to what is specifically stated in the ISP?
Yeah, because when we determine neglect, we always look at what was the risk as it's associated with the service plan. So if somebody's supposed to have, 10-minute checks and they don't get 10-minute checks and there was a risk, but after 15 minutes they were still okay, those are the kind of short periods of supervision that wouldn't necessarily need to be filed as an MUI with under the new definition. Got it?
Good questions. Keep them coming.
Yep, absolutely. Okay, some of the Category C changes. Our law enforcement definition, you guys know that one always is if somebody's charged, incarcerated, or arrested. And we had, believe it or not, and I know this is hard to believe, but we had several instances where some individuals we support were tased, and people wondered if that was a reportable incident. And we said that's pretty significant. If somebody gets tased, let's report it as a law enforcement incident. So in case that were to happen, that category has been expanded to include those kind of particular cases. And then there was a lot of discussion about unscheduled hospitalization, and the committee landed, rather than calling it unscheduled, the committee believed it was better entitled unanticipated hospitalization, because we're talking about something that's not scheduled, not pre-planned. So the new definition will be unanticipated hospitalization. And we've had this issue since the last rule about admission. The last rule, the definition was focusing on the hospital admission. And sometimes people, some of you might have an example of this, but I was told and know that it happens. You might go to the hospital and be held for a pretty long period of time, but never officially admitted. So people are saying, well, that's not an MUI because you never were officially admitted. We tried to clear this up by saying, if someone goes to the hospital and they're being held and they're there for 24 hours, even if it's not an official admission, we want it to be filed as an unanticipated hospitalization. And that way it's very clear. Before we had to kind of wait and someone wouldn't say whether they were officially admitted, so we didn't know if we had an MUI. We're getting rid of that. If somebody's in the hospital more than 24 hours, it's an unanticipated hospitalization. We report it and we'll look into it. So I hope that makes sense. I think that's something that will make it a little easier to make that determination. And then unapproved behavior support is going to be changed to align with the behavior support rule. And the name of the MUI will be changed to the unapproved behavioral support to match that rule and include that rule reference 5123-2206. So the next part what we're going to talk about is, as I mentioned in the beginning, we talked about how we could do a better job of communicating, how we could make sure that the system communicates well with all the players involved. And some of these bullets are going to address how we're going to try to do that. The first one there, except when, and remember, this is when law enforcement or children's services is not doing the investigation. So if the investigative agent's doing it on their own, we put this language in, shall endeavor to reach a preliminary finding regarding the allegation of physical abuse or sexual abuse and notify the individual or individual's guardian and provider of the preliminary finding within 14 working days. We're going to do the best we can to do that. Now, with that said, we all know, especially when police and children's services are involved, it's hard to get something back in that kind of time frame. We're going to work hard to make sure we do it when we're the only ones accountable. But even when we're just the investigative agent at the board is accountable, there's going to be times when you can't get all the information you need to have the preliminary outcome within 14 days. So that's why the language is such that we're going to, work hard to get it done, endeavor to reach that conclusion. But if for some reason we don't get it done in 14 days, we don't have the preliminary finding, the goal is to communicate with the provider and the family about what's going on, what's happening. And this gets back to what I said earlier about trying to make sure that communication happens throughout the investigation process. And we think this will be a good way to do that. So hopefully a lot of the cases will be resolved within that period. If they're not resolved, then the communication as to where we're at and what's going on should happen with the players involved to make sure that that makes sense. And I think that was a good place to land when we talked about people being concerned about knowing something was reported and really not finding anything out until they get the written summary some, 30, 60 days down the road. Some other things to talk about is agency providers implementing a written procedure. And the goal in this piece is the procedure that requires senior management of the agency provider to be informed within 2 working days following the day staff become aware of the potential or determined MUI. And when it involves theft, neglect, physical abuse, or sexual abuse. I want to give you a little bit of background on this recommendation. This one came from the stakeholder group when we got the Office of the Inspector General report. Many of you know those reports have been, several states have gone through the OIG review of their critical incident report system. There's been a lot of concerns about the outcomes of those. As a result, the OIG, in conjunction with multiple groups, put together some best practices. One of the best practices they had that I didn't feel like Ohio met, we didn't feel like Ohio met, was the notification of senior management about MUIs. And when we brought this up with the committee, most of the folks from the provider sectors and the stakeholder committee said, well, if we're doing our job well, those folks want to know. They want to know when we have these kind of cases in our system, and we're probably doing that already, but some may not be. And as a result of that, we decided to include some information in the language that just basically says, put in your policy and practices how you're going to be assured that senior management is aware of these significant MUIs that are happening within your entity. So that the combination of the OIG report, the discussion in the stakeholder committee, and what we're trying to do in terms of best practices in Ohio is what kind of really resulted in this language change.
We have a question back on IVs that came in while you're talking about this. If an individual has a procedure and is decided to admit to observe or for IV meds, but less than 24 hours, this is not an MUI?
Yes, if it's a general IV and they're in the hospital less than 24 hours, it wouldn't be a required report. That's correct.
And
That's a good question. Go ahead.
In relation to a procedure that was planned? That. Well, I guess it's
so if a planned procedure wouldn't be anything that we would report either. So I will tell you this though, and this sometimes gets some questions. It's a good question, but I'll elaborate on it a little bit. If somebody goes in for a planned procedure, and then during that planned procedure something happens, and they are now subsequently hospitalized, that is a reportable MUI because that's not the reason they went in for the planned procedure, and now they're being admitted or they're in the hospital longer than 24 hours. So. We have that question periodically, so I hope that helps. Okay, the provider providing services when a UI occurs shall notify other providers of services necessary to ensure continuity of care and support for the individual. A little background on this one was we had people in the committee say there's still times when something happens to someone and I don't know about it, and then they come into my place and then I have to do all this paperwork and all this follow-up because we don't know what happened. So the key is we don't want surprises for anybody. If you're a provider of service, something happens to a person and they're going somewhere else, the goal of this section is to try to make sure that we make that communication happens so that families, individuals, providers, day programs, boards, all have information to know that something happened, it's been reported, being looked into, and someone doesn't just come in with a huge knot on their head and nobody knows what happened. So trying to improve a little bit in our communication. And this is in relation to, MUIs specifically, but could be in relation to UIs as well, especially if there is a significant injury of some kind. We should make sure we're making those communications. The next one here is pretty straightforward. We just talked about in doing the abuser registry work for the department, some providers had concerns about whether they could share information about date of birth or social security number because the previous rule says those will never be shared. We just wanted to make sure it was clear. You could share that with the department when we're taking action in terms of the abuser registry. So there's some language included here to clarify that.
Kim had a quick follow-up on our IV question.
Mm-hmm.
So you file an MUI only if it's more than 24 hours.
If the person's in there longer than 24 hours, yep. And it's not for a planned procedure. Yep. The next one here, and there was quite a bit of discussion about this one too, and this comes back to kind of the perception of what an employee feels when they're going through some kind of investigation. And many providers of service out there, if it was abuse, physical, sexual, or neglect or theft, they were placing that person out on leave for all of those kind of incidents. And we've seen some through the department review where, it doesn't look like that necessarily would be required. And we put some language in here and changed. What we did was basically remove neglect. So in this particular definition, neglect is included in the current rule. So people felt like anytime there was a neglect allegation, that the person had to be removed, which is not necessary. So again, it's up to the provider to make this decision. They need to obviously work with the board to make sure that the board understands what immediate actions are going to be taken to protect the person. But it's the provider's decision to be made on whether or not someone is removed. And basically this just says we remove neglect out of here. I mean, for physical abuse and sexual abuse, I think it makes sense to make sure that the person's not there. That protects them, that protects the victim. But some of the neglect ones where it got a little bit cloudy, and so we want to make sure that that was in there. And they also wanted to make a quick note here, nothing precludes an employer from removing a person for whatever they think they need to, given whatever that allegation is. So we really didn't want people thinking they had to remove somebody for neglect. I mean, the example I used earlier, somebody didn't supervise somebody for 5 minutes, there was no outcome. Would that person have to necessarily be placed on leave? I would hope not in most cases. So just want to make sure that we provide some clarity and background on that as well.
Could you go back 2 slides?
Uh-huh.
Yep, there we go. So April asked, do UIs need to be reported to other providers? PowerPoint says UI, but in the conversation, in discussion of.
Yeah, as it relates to this section, the whole point of it was to make sure that no provider is surprised. If you're a provider that's responsible when something happens to someone, and you know that someone's going to be involved now with another provider of service, whether that's residential or day program, no matter what it is, we want people to make that effort to notify folks that has happened. Does that make sense?
Scott, this is Jeff. The purpose there was that if you think there is going to be some resultant or ramification or as a part of in response to something that has happened, and it might affect the subsequent service delivery, or it might affect the individual's behavior, might affect their health, then that courtesy you need to share that so that provider is aware and ready to act on that if necessary. That's not necessarily saying that you report all UIs to the next provider. You're really in some respects, you're using your judgment out of professional courtesy to make sure in the best interest of the individual if you think something might have a result. Is that kind of fair to say?
Absolutely, yep. I mean, somebody could come from home to work and be really upset that something happened, or somebody could come from home to work and have an injury that the person can't communicate what happened, and the receiving provider has no idea what's taking place. So just trying to make sure that we increase our communication in terms of health and welfare outcomes.
And Wendy asks, how will this be enforced? I think specific to the provided communication, correct, Wendy? Yes.
Okay. The way this will be enforced is obviously if we want communication by providers. If somebody gets there and it's not happened, certainly they can call the provider, and in that way, certainly that helps. It'll be enforced like all areas of the rule are. It'll probably be reviewed through compliance reviews and follow-up to make sure that those kinds of things are happening. There's really no other way to do it. If there's an ongoing problem, certainly we can, the board should be contacted, or even our department contacted if somebody's not, making the notifications as they should. I'm hopeful that this will be pretty clear in the training and people will understand it's a cursory courtesy notification that people are doing it.
Sort of a common sense approach.
Yeah, it really is. I use this example, and I think, one of our staff even mentioned it. If I take my son to daycare and something happens and I go to pick him up and nobody's notified me and he's got a big black eye, I'm gonna be ticked off about it. People should be notified of those kinds of things so they can take appropriate action and plan for what needs to happen. So,
do you have any other questions? Wendy says, lots of things are common sense, doesn't mean it happens.
That's a good point. I agree. Some things seem so common sense, but anyways, to follow up, though, if it's not happening, make sure that the board or the department is made aware, and certainly we can follow up as well. All right, so we're here. The other thing we want to do is we want to try to eliminate the filing of multiple MUIs for the same incident. And I'll just give you an example. Let's say we had somebody who was taken to the hospital with a broken bone. It was a result of a significant injury, and we determined that it was neglect because the supervision for that person didn't happen the way that it needs. So you've got neglect, you've got a significant injury, you've got an unanticipated hospitalization, but it all relates to one event, one incident that happened. And this is probably more for the board than it is for providers, but we want to make sure that we then can capture that in the highest level. So for that example I just used, we could capture that as a neglect MUI, note within the document that it also met criteria for a hospitalization and an injury, and make sure that the prevention plan made sense. So it's going to reduce, that's kind of, remember when we talked about some of the administrative, the burdensome work, we're trying to take a look at that and see how we can help make sure that there's not more work than is necessary. What happens now is there's a lot of cut and paste documents in these multiple MUIs that are filed that's very similar. That's not really necessary. So we're hoping that that will make some extra time for everybody involved in terms of filing those processes. Next one, removing semi-annual analysis. There was a lot of discussion about this. And my concern is we still have got to have eyes on patterns and trends and totals within provider entities. You know, we decided we would remove the semi-annual analysis requirement, but what that means is we're going to expect a lot more out of the annual to make sure that it's done and done well. And that's something that will be reviewed through OPSR to make sure that we are doing a good job of doing the annual analysis, making it thorough, identifying patterns and trends, looking for folks that are high flyers, and trying to make sure that as an entity we do a good job of follow-up. And I think that the feedback we got from providers on the stakeholder group felt like that if it was an annual event, people would really take the time to dedicate to do it and do it well, and then we would have some good outcomes. So I think that's where we landed there. Written notifications to the PPI will only include DD employees. There was a lot of questions from the committee about, primarily from boards, about giving notice to PPIs in cases. And remember, PPIs are the primary person involved or the alleged perpetrator. And if, for example, if there was an allegation against the guy that owned the carryout down the street, we're not saying there's got to be notification to that person. So we're identifying DD employees as the ones that require the official notification on the outcome of an allegation. And some people felt like they were kind of chasing their tail, trying to track down how to notify someone that wasn't really part of our system, and that's not required. All right, so let's see. Whoops. I'm missing some slides here. So I have a few slides I want to talk about that aren't necessarily here, and I guess it's more implementation. So again, I'll make sure that Anita, Christine, and Jeff have the one that has all the information in, but we want to talk about when this goes into place and we implement it, what are some considerations that we got to think about? And I guess one of the first things is to develop your training on the rule revisions with the changes included and making sure that that happens. And we're going to try to do, as I mentioned, webinars, YouTube videos, Facebook Live. We're going to put a lot of things out there so you can get this information and you can make sure that training happens, and then you can absorb it within your own entity and add that information accordingly for your internal training. So we'll make sure that happens. Make sure that the definitions are all updated, and we put some examples here of some of the ones, we talked about neglect, we talked about prohibited sex, or we talked about some of the program implementation UI definition, the change to unanticipated hospitalization and unapproved behavior supports, making sure that we update those definitions. Making sure that the training includes senior management and involves those people. How are we going to make those folks aware? Who's going to be the folks that we got to make sure we notify, making sure that we do that kind of stuff when we're thinking about implementation. Provide your MUI rule training to your board members for county boards and for providers. The board members are added as DD employees. We got to make sure that those folks have the information or are knowledgeable about MUIs and what's expected. Ensure that supervisors have the training on how to conduct unusual incident investigations. As I mentioned earlier, the only way this works with making the changes that we did is to make sure that those UI investigations are thorough and are good. And I know that I've just seen a bunch of them. I know that providers are doing a terrific job now. more than ever, when this rule goes into place, there's going to be a lot of scrutiny, particularly of the definitions that we're changing, to determine how is Ohio handling that and how are we addressing it. And so there's going to be a lot of ownership on providers to make sure those UI investigations that used to be MUI investigations are done and done well. Utilizing social media and agency newsletters to inform your staff and stakeholders of upcoming changes certainly is going to be important. Revising and reporting policy to include senior management notifications. And again, we talked about that. Remember, that's the result of the OIG reports and then some good discussion that we had in the stakeholder groups. Obviously, you're going to have to take a look at your forms, if there's any term changes, any name changes, trying to make sure that those are done and completed and updated. And then your incident reports and your UI logs. We did put some language in, and I want to make sure I address this. We did put some language in the rule that identifies what we really expect to see in the unusual incident logs. And really, it's those more pertinent UIs. Again, as I mentioned earlier, we were talking, UIs can be done for anything. You know, I've seen UIs for mosquito bites. I've seen UIs for, you know, sunburns that really aren't bad at all. I mean, I've seen UIs for a lot of things. What we want to make sure happens and what makes sure gets on the log is those that are more significant, like the dental injuries that aren't an MUI or the falls that aren't an MUI, overnight relocations of a person, the natural disaster or mechanical failure, a furnace goes out and we have to move somebody, peer-to-peer acts that aren't MUIs, rights code violations that don't have really a likely risk of harm, emergency room or urgent care treatment center visits. I do want to talk about that for a minute. And Jeff, maybe you remember, we had a lot of discussion in the committee about this, and that the OIG report, when the OIG came into states, they looked at Medicaid data on hospital admissions, and they also looked for emergency room, urgent care visits. And when they did not see a corresponding critical incident for an emergency room or urgent care visit, they had concerns about the critical incident reporting system. And you guys know, by virtue of our definition, we don't require an MUI for an emergency room visit. So the importance is going to be, if you have an emergency room visit, that you do a UI and that you do a good investigation as it relates to it, because that's going to be identified as an issue for the state of Ohio, likely when the OIG, if the OIG comes to Ohio. And we want to be able to say that even though it's not a critical incident reported as an MUI, it's addressed as an incident, it's investigated through the providers of service, and it's looked into. So I hope that makes sense. That's a little bit of a difference between an unscheduled or unanticipated hospitalization and an emergency room visit. We just got to make sure that we document it and have it captured. And then obviously anything that's a program implementation incident based on our new definition, draft definition of that. So basically, kind of to wrap up that piece, UI investigations are going to be critical to the success of these changes and these system changes. And so as a provider of service, if you can really make sure that you're comfortable with the investigation that you get on your UI reports, you know, even though I know, and we know we can't solve every issue, I certainly know that, but the fact that we make a good faith effort to look into something that impacts somebody's health and welfare in a way to try to prevent it is going to keep us from, you know, getting scrutinized in a way that people are saying we're not taking this serious enough. We got to make sure that we do that. So I hope that makes some sense. I wanted to take, well,
we got a good question.
Sure.
Which I think is a good one. Kimberly asks, when you are talking about multifaceted MUIs, neglect resulting in emergency medical treatment, which resulted in unanticipated hospitalization, how is the different categories of investigation taken into account with this, and different investigators for different categories?
Yeah, and what we're going to try to do with the new language is to make sure that people know that we file it as, you know, the higher level incident. So in that case, the example I use would be neglect. The protocol for a neglect investigation is going to be required, and that's what the investigative agent, the type of investigation that they'll be conducting, and that's going to be the expectation that we have in our oversight of those cases as they come in through the incident tracking system. So I hope that helps. And there's going to be a little bit of feeling out period, working this through, just trying to make sure that we do a good job of identifying specifically the incidents we're looking for, and then the outcomes that are expected based on that definition. So, I mean, obviously, you know, there's a difference between what we would expect for neglect and what we would expect for a significant injury. I mean, we want a little bit more. So I hope that helps.
It does.
Okay. So one more thing, I know Does anybody have any other questions? That's all for in terms of the bullet points for the rule revisions. Anybody have any questions on anything we've covered to this point? If you do, you can go ahead and include them. I want to cover a couple quick things. We got about 10 minutes, and I wanted to, and Jeff, I didn't tell you specifically about this, but I know you want me to do this. I wanted to talk about just some patterns and trends that we're seeing that you guys can. I want to make sure you're aware of, so you can get out in front of them in your world to make sure that we do that. And the first thing is choking prevention, and this isn't a surprise to you. Hopefully, all of you saw the director did a real nice piece where he talked about choking in Ohio. We also have an alert that's out there that we paired an alert with a video. I hope all of you saw it. If you didn't, I suggest that you get it and you see it and you use it for your staff training. We ended up finding a direct support professional who worked for an agency in her career, and she's been a DSP for a long time. In her career, she saved 5 people by doing abdominal thrusts and back blows. That's unbelievable. I mean, to me, that's just incredible. And so we paired our alert for choking with her story about how important it is and what she's been able to achieve. And I can't help but think that if you showed the alert to your staff and you paired it with this video, that the next time somebody goes to do a meal or to provide support to somebody when they're eating, they're not going to think about it a little bit differently. I just know that's the case, and we've got a lot of feedback that people have been successful there. So if you haven't used it, use it. And if you are using it, keep using it, because we can't never talk enough about choking. We are up trending wise on choking deaths in Ohio this year. We're probably going to have, unfortunately, our highest number of choking deaths that we've had in the last 5 years this year. But we're getting the word out. We're trying to make sure that people are clear. And the key pieces to train your staff on: diet textures and supervision. Those are the 2 big things. Make sure people understand the diet textures. Make sure they're preparing it as it's assigned and as it's been prescribed. And then the supervision, trying to make sure. And I know, because trust me, I've been in the field a long time. Meal times are crazy times, chaotic times. I know that, but doing the best you can to make sure that people get the appropriate supervision, because it just breaks your heart when you see a case where, somebody didn't have the right texture and they choked and passed away, or somebody didn't get the supervision that they were supposed to get and they choked and passed away. And so it's really, really important. The good news, there is good news in this story, is last year we had about 469 medical emergencies for choking, and I think 455 of those were successful. It's like 95% of the time people were successful. That means we're doing a good job. The bad part is we still have that 5% where we haven't done it. People have passed away. Anytime we lose one person, that's one person too many when it comes to this kind of case.
We just have a question about where is that video? Is that?
Yeah, if you go to the DODD website, dodd.ohio.gov, go to Health and Welfare, click on Health and Welfare, drop down, there's an alerts section. So all of our alerts are there. Go to the choking alert, and the video is embedded within the choking alert.
We'll put a link up to that when we send out the updated PowerPoint and the recording. And then just we had a couple people, these are supposed to go in January 2019 as a go live date.
For the new rule stuff, yep, January. We're right now, our expected time is the first of the calendar year in 19. If that changes, obviously we'll let you guys know, and we'll keep you posted. But we're hoping to have everything back from the governor's office, to have had the hearing, and to have a set date after that. Good questions. Other questions there? The other thing I wanted to talk about is medication administration, and we are still seeing quite a few med errors that are resulting in significant risk. And I think all of you know, and we did a medication administration alert. Paired with that alert was also a video, and that one, if you haven't seen it, it's the story of Alex Myers. And Alex was a gentleman who lived in Ohio, passed away from a medication error. His family did a video, a tribute to him, and it's a really, really well done tribute to him, but it also talks about the concerns of the family about what happened to Alex and trying to make sure that doesn't happen to somebody else. So pairing that medication administration alert on what to do it, how to do it well, with the video of a family who lost a loved one based on a medication administration error, again, I can't imagine that your employees aren't going to walk away with a whole new understanding and reality about how important those med passes are and how important it is to pay attention and to try to make sure that people always get the right meds, that they're supervised when they're getting their meds, and all those kinds of things. So, and then just a couple more quick things as we're wrapping up. Transportation concerns, and I'm only going to throw out a few bullets here, but we still have cases where people are getting dropped off and there's not somebody there to supervise them in a lot of different ways. So making sure that there's a connection, whether it's in the plan specifically or not, with assuring that a person doesn't get left somewhere when there's not someone there to provide supervision. We're seeing quite a bit of that still. Also seeing situations where people are getting secured if they're in a wheelchair in the van or the bus. The wheelchair itself may be getting secured well, but forgetting to put the person's buckle on in their wheelchair, and the first time you hit a stoplight or a stop sign, someone comes flying out of their chair. So making sure that we really do a good job of transportation and that people are well trained on how to secure somebody safely, because we've had a lot of bad injuries, head injuries, where wheelchairs have tipped over, someone hits their head, and they get a real bad injury. We even had a person pass away related to that kind of scenario. So trying to make sure that people are well secured in the vans for transportation. The other thing, and this one blows my mind, but I really want you to take it and talk to your employees about it. If you have a lift, any kind of a lift on a van, on a bus, on anything, making sure that people are really clear. We've had two real recently where people have pushed people off of a vehicle onto a lift that they forgot to bring up. And, sometimes the employee goes right off with the person. I mean, trying to make sure that the lifts are in place when you're doing it. I know it seems silly to have to even think about that, but when you see cases like that, and those result in significant injuries as well. So making sure that we think about the lifts and using those appropriately and making sure that they're safe. And then the last thing is just transition. We've seen a lot of MUIs related to people moving from one day program to another, from one work site to another, from one home to another, from an ICF to a waiver, making sure that the transitions happen and happen well. I can't express to you enough how, we just had a really tragic one where someone didn't get the diet textures right. The sending person didn't have it right for the receiving person. The person got something once they got there they shouldn't have gotten, and they choked, and that person didn't pass away but is in the hospital and is not doing well. So just something as simple as making sure that people know what the diet texture should be, what the supervision level should be during meals, what kind of adaptive equipment somebody needs, what kind of interventions we have in the plan for challenging behaviors to make sure that people are prepared, because sometimes that might happen on the first day. And if I don't know how to intervene appropriately, an incident could blow up that may not necessarily have to blow up if people have the education and the information that they need. So I just wanted to throw some of those out to you. I know some of them seem very simple and straightforward, but when we're seeing cases like this, it's important, I think, for me to share with you and let you know that we got to get out in front of some of these kind of cases, because many of them are preventable. And if we do a good job with training our staff and providing supervision to our staff, we can prevent some of these kind of things from happening. So, and then the last one here, I also know that we are going through so many different changes, and I'll be honest with you, many of the changes are so positive. I don't remember a time in my career, and it's a long one. You guys know I'm old, so where there's been so many different things happening, but there's so many opportunities, and we just got to take advantage of it. And if you guys can all do me this favor and share with your staff and share with folks that the MUI system is a quality improvement system. We want to try to protect people. We want to keep people healthy and well, and we want to do it in a way that makes sense for the system that we know is challenged right now in a lot of ways with staffing and training and stuff like that. I know that's hard, but we got to do the very best we can to make sure that we protect people, and we do it in a way that makes sense for the people that are providing services. So thank you very much for the work that you do. I say this all the time to Jeff and Anita, and you guys know I have a background in residential services. Direct support professionals and providers are the backbone of everything that we do. And we wouldn't have the system that we have unless you were there and doing your job very well. So thank you for the work that you do. And hopefully these changes will be helpful moving forward so that we can continue to protect people and continue to provide supports in a way that makes sense. So any other questions before we kind of wrap up? I know we're getting close to our time frame here.
Scott, I want to thank you. You know that, and I've said to you many times, and I want to echo your comments on the work group. You created an environment where we can have these kinds of discussions. We came to the table, right, and saying to you that we feared that the system, had an adverse effect at times on DSPs, and you listened and made a number of the changes, really a lot of the changes that we talked about in depth. So we're very appreciative for that. We will follow up here with, we'll record this. This is being recorded. We'll send out the PowerPoint. We'll send out the links to a couple of things Scott talked about in the videos, and we'll make sure everybody has it. And we'll see you again in September, but we can't stress enough how appreciative we are that
You bet. You bet.
you came over and visited.
You bet. Have a good day, guys.
Thank you,
Thank you.
everybody.
Thank you.